Very good morning. Thank you, Dr. Vishali, for this opportunity. I'll be showing 4 case examples where the ICG provided us information where fluorescein could not be really helpful. The slides are not moving. Thank you. It's not moving from here. So we had this 35-year-old woman who presented to us almost 3 years ago in January as a diagnosed case of leakage disease since 2 months, and she was receiving tapering dose of oral steroids, that is 40 milligrams of prednisolone, by the treating doctor elsewhere where she was residing. So she just came for a second opinion. At that time, her visual acuity was 6.9 in the right eye and 6.6 in the left eye. The fundus was normal, and EDI OCT showed some choroidal thickening. And so we advised her to continue her treatment, whatever she was taking and follow up at the primary center. So this is what she had the picture look like, and if you can appreciate the choroidal thickening on the EDI scans in both the eyes. So 6 weeks later, she happened to come to us again with some pain in the left eye. She was at this time on 20 milligrams of prednisolone. The visual acuity was same as before, 6.9 and 6.6. The fundus was normal. So when we did the EDI OCT at this visit, there was significant choroidal thickening in both the eyes, although there was no subretinal fluid. So probably this was the stage of subclinical recurrence. We increased her prednisolone, which she was on 20, to 70, and also added azathioprine. So she kept on visiting us for regular follow-ups, and till June that year, that's 5 months of follow-up, she was fine with 6.5 vision in both the eyes. The fundus was normal and no clinical findings. So this was the OCT. You can the EDI OCT at the follow-up, and you can compare with the bottom panels, which she had at the baseline as choroidal thickening. In October that year, she came with some discomfort in the left eye, not really very symptomatic, but she was quite sure about the discomfort she had in her left eye. The vision was 6.6 in both the eyes. There were no cells in the anterior chamber or in the vitreous. The fundus examination was again normal in both the eyes. So when we repeated the EDI OCT, her right eye EDI OCT was normal, as you can see on the top panel, but the left eye showed massive choroidal thickening. Now, we plan to take her up for the combined FFA and ICG, and what we saw, if you just look at the FFA frames, the fluorescein angiography was grossly normal in both the eyes, except that there was mild disc hyperfluorescence in the late phase of the left eye. But when we look at the ICG, the early phase was normal in the left eye, but we could see some granulomas in the late phase in the left eye. So this confirmed our diagnosis of a subclinical recurrence, which we really didn't see anything on the fluorescein, and which was guided by the EDI OCT. So this was the late phase, and on the follow-up, we monitored her, and 3 weeks later, when we stepped up her immunosuppression, the ICG was repeated again, and this showed resolution of all the granulomas, which we had seen earlier. So EDI OCT here provided us the first-hand information in a non-invasive way, and the ICG helped us to confirm the diagnosis of a subclinical recurrence, which could not be confirmed on the fluorescein angiography. So this was a second case, a young male who presented to us with bilateral loss of vision over a period of 10 days. And he was actually seen by a local ophthalmologist elsewhere, and was because of these obvious findings of disc edema and a peripapillary hemorrhage, he was referred to as case of papilledema. So what the primary physician probably missed out was looking at these discrete yellowish subretinal lesions, not very well defined, but they're distributed all over the posterior pole. And on quick detailed examination, we also found some vitreous cells. So obviously this was not papilledema, and we did see some choroidal lesions. A combined FFA and ICG in this case was done, and you can see if we look at the early frames of the right and left eye, we do see some kind of hypofluorescent lesions in the fluorescein. But if you look at the ICG, the simultaneous ICG, it reveals much more information than the fluorescein. You can see multiple granulomas all over the fundus in both the eyes in the early frames, And this is what the late frame FFA showed, disc hyperfluorescence, not much increase in the number or the hyperfluorescence of the granulomas, but yes, the late phase ICG did show all these granulomas remaining hypocynoscent. This is another case where the ICG was used as a monitoring tool, not only for diagnosis, but as a monitoring tool to judge the response to therapy. The top frame is the early frame in the left eye, where you can see some granulomas in the ICG and not on the fluorescein. And these granulomas persist in the late phase of the ICG. And whereas the fluorescein shows only disc hyperfluorescence, so we did follow this patient while on treatment, repeating the ICG. And if you look now, repeat the ICG and compare it with the old ICG, we see that many of these granulomas have resolved with treatment in the early phase. And if you look at the late phase, not only the disc hyperfluorescence is gone, but all the granulomas of the ICG have resolved with treatment. The fourth case is a case of chronic CSE patient, where you don't see much changes in the fundus, and the fluorescein shows stippled hyperfluorescence, which remains the same in the early and the late phase. When we do the OCT, we see some flat, irregular elevation of the RPE, and with some mixed hyper and hypo-reflective material underneath it. When we do the ICG, we see in the early frames, we see some plaque of hypercynoscent senescence in the macula. You can see by the delineation by the arrows, which persists in all the intermediate and the late phases. So this was a choroidal neovascular complex, which was confirmed on the OCT Angio. So ICG here helped us again to pick up the choroidal neovascular membrane, which could not be picked up on the fluorescein angiography. Thank you very much.